Welcome back to the Deep Dive. Today, we are doing something a little different. This isn't just a deep dive, it's a drill.
It's a coaching session.
Exactly. I want you, our listener, to just mentally shift gears for a moment. You're not at the gym, you're not on your commute, you're in the hot seat.
You're an MD anesthesiology resident.
And the Gujarat University exams are looming. Maybe they're next week, maybe tomorrow. The examiners are staring you down, and the topic on the table is one of the absolute pillars of our specialty.
That's right. We are tackling a topic that is, it's fundamental. It's asked all the time. And yet, surprisingly, it's a topic where people frequently fail.
What are we talking about?
We are talking about hypoxia, types, causes, and management, and the effects of anesthesia on respiration.
It sounds so basic, doesn't it? Hypoxia, lack of oxygen. It feels like, day one stuff.
It does.
But looking at the stack of sources we have here, we've got the standard physiology texts like Guyton and Ganong. We've got the anesthesia Bibles like Miller and Morgan, Yao and Artuzio for the case-based approach, and then clinical protocols from Harrison's and various ICU guides. This is anything but simple.
It's deceptive. And you see, that is where the danger lies for you in the exam. If you treat this casually, you will miss all the nuance.
So this isn't just about reading the textbook.
Not at all. This is about structuring an answer. It's about securing those 10, maybe 20 marks in the theory paper, and maybe even more importantly, surviving the grueling cross-questioning of a viva.
Okay, so you're playing a role today.
I am the senior faculty, and I'm going to emphasize precision. Precision in your definition, precision in the mechanism, and absolute precision in management.
I love it. Senior faculty mode is engaged. So, Part A, Introduction and Exam Framing. Where do we even begin? Do we start with the lungs?
No, and that is the very first mistake that most students make. We don't start with the lungs. We start with the currency of life. We start at the destination.
The mitochondrion.
We start with the mitochondrion. You have to establish the physiological imperative. Why do we breathe? It is not just to move air. It's because oxygen is the final electron acceptor in the mitochondrial electron transport chain.
Okay, let's unpack that right away, because that sounds like we're drifting into, first-year biochemistry. Why is that the opening line for an anesthesia exam?
Because it establishes the stakes. If you don't mention the electron transport chain, you haven't explained why hypoxia kills.
Right.
Without oxygen acting as that final acceptor, aerobic metabolism just halts. The Krebs cycle stops. Your ATP production crashes from, a robust 36 or 38 ATP per glucose molecule?
Down to what?
Down to a pathetic 2 ATP via glycolysis. You switch to anaerobic metabolism, lactate builds up, cellular pH plummets, enzymes fail, and, eventually, cell death.
So hypoxia is the common enemy.
It is the common enemy.
Yeah.
It doesn't matter if you're in the OT, the ICU, the recovery room, or in emergency medicine. It is the final common pathway for almost every single anesthetic mishap.
And in terms of the exam itself, how does this question usually show up? Is it a viva question? Is it written?
It's everywhere. It's ubiquitous. In theory papers, you'll often see it as a full-long question worth 20 marks. Something like, classify hypoxia, discuss the pathophysiology, and outline the management.
Okay.
Or you'll get short notes. Hypoxic pulmonary vasoconstriction, oxygen cascade. But in the VIVA or the OSCE, it is an absolute favorite starting point.
And here comes the warning.
Here is the warning. If you fumble the definition of hypoxia in the first 60 seconds of a VIVA, you have set a very, very poor tone for the rest of your exam. Examiners are looking for precision.
Right. Precision is key. So that brings us to Part B, definitions and classification. This is absolutely essential. So if I'm the student and you ask me, Doctor, define hypoxia, what is the examiner's safe answer?
The first thing you must do is distinguish it from hypoxemia. This is the first trap. Hypoxemia is defined strictly as low arterial oxygen tension, low PO2. Sources like Harrison's will cite thresholds, less than 60 millimeters of mercury for severe hypoxemia, maybe less than 80 for mild, but that refers only to the blood.
And hypoxia.
Hypoxia is a deficiency of oxygen at the tissue level. That is the critical distinction.
You say one's in the blood, one's in the tissue.
Exactly. And you can have hypoxemia without tissue hypoxia if your body compensates well enough, say, with increased cardiac output. And, crucially for the exam, you can have severe tissue hypoxia without any hypoxemia at all.
Ah, that's the gold for the examiner, isn't it? The edge case. Give me a concrete example of that. Hypoxia without hypoxemia.
Cyanide poisoning. Absolutely classic. Your KO2 might be totally normal. Your blood is full of oxygen.
But the tissues are starving.
They're starving because the mitochondria are poisoned and can't use it. Or think about severe anemia. The oxygen pressure, the PO2, is fine, but the content is dangerously low because there's no hemoglobin to carry it. The bus is empty.
That's a great analogy. Okay, so that's a crystal clear distinction. Once we've nailed that definition, we move to classification. I see references to the classical classification here. Is this the Barcroft classification we need to know?
Yes. For the Gujarat University exams, and frankly for any major board exam, you stick to the physiological approach that's attributed to Barcroft. There are 4 main types. You need to memorize these cold.
What are they?
Hypoxic hypoxia, anemic hypoxia, stagnant or circulatory hypoxia, and histotoxic hypoxia.
4 types. Simple enough, but I see another term here in our stack, dysoxia. Is that a 5th type I need to worry about?
It's a term you'll see in the critical care texts. Dysoxia describes impaired utilization, usually in the context of sepsis or mitochondrial failure. It's good to be aware of.
So a bonus point.
A bonus point. If you're pushing for a gold medal, you mention it as a nuance of histotoxic hypoxia, but for the standard exam, stick to the classical 4. Don't overcomplicate it until you've absolutely mastered the basics.
Got it. Okay, so let's break these down. This is part C of our plan. Mechanisms and causes. This feels like where the bulk of the marks are in the theory paper. Start with number 1, hypoxic hypoxia.
Right. So in hypoxic hypoxia, the problem is upstream. It's in the lungs. The mechanism is inadequate oxygenation of the arterial blood itself. Low PO2 leads directly to low SO2.
So this is true hypoxemia leading to hypoxia.
It is. The lungs just aren't doing their job.
Okay, what are the specific causes we need to list out in the exam?
You need to be able to rattle off 4 distinct pathophysiological causes. Just think of the path of oxygen. First is low PO2, low inspired oxygen tension.
Like going up to high altitude.
Yes, that's the textbook physiology answer. But you need to think like an anesthetist. In the operating theater, what causes a low PO2? It is almost always iatrogenic.
We caused it.
You caused it. A hypoxic gas mixture. You failed to turn on the oxygen cylinder. There's a disconnect in the breathing circuit. Or, and this is more historic but still important, a failure of the hypoxic guard on an older anesthesia machine.
Right. High altitude is nature. A hypoxic mixture is negligence. Okay, what's the second cause?
Hypoventilation. And this goes right back to the alveolar gas equation. Now, we don't need to derive it here, but the concept is absolutely crucial.
Let's simplify it for everyone listening. It basically says the alveolus is a finite space, right?
Exactly. Dalton's law. The total pressure in the alveolus is fixed at atmospheric pressure. If you start filling that space up with CO2 because you aren't breathing it out, that's hypoventilation, there is physically less room for oxygen molecules.
So as PaSO2 goes up,
your alveolar oxygen, PaO2, must go down. It's simple physics.
And the causes for that in our world are pretty obvious.
Extremely common. Opioids, residual neuromuscular blockade, deep sedation, the classic post-op narcotic effect.
Okay. Third cause.
Diffusion defect. This is a thickening of that alveolar capillary membrane. Think of things like pulmonary fibrosis, asbestosis, or severe interstitial lung disease.
How significant is this really in day-to-day practice?
At rest. It's rarely the sole cause of hypoxia unless the disease is truly end stage. Oxygen equilibrates across that membrane incredibly quickly, usually within the first 1/3 of the capillary transit time. But if that patient exercises, which increases cardiac output and speeds up blood flow, or if the membrane is very, very thick, then the blood might just leave the capillary before it's had a chance to get fully oxygenated.
And the fourth cause of hypoxic hypoxia.
The big one, the one you see every day. VQ mismatch and shunt. These are by far the most common clinical causes in the ICU and the OT.
Can we differentiate them clearly? I feel like people sometimes use VQ mismatch and shunt interchangeably, but they're not the same thing, are they?
They're on a spectrum, but the distinction is vital for management. VQ mismatch implies poor ventilation relative to perfusion. Wow. So think of asthma or COPD. Some air is getting there, just not enough to match the blood flow.
And a shunt.
A shunt, specifically a right-to-left shunt, means blood bypasses ventilated alveoli entirely. It gets zero oxygenation.
Like a VSD, a hole in the heart.
That's an anatomic shunt, yes. But in anesthesia, we're usually more worried about a physiological shunt, atelectasis, pneumonia, pulmonary edema. A blood flows through a part of the lung that is completely collapsed or full of fluid. It enters the left heart having never seen an oxygen molecule.
And that distinction is critical for management, which we'll get to later.
Yeah, absolutely.
Okay, so hypoxia is essentially lung failure. Let's move to the next one, anemic hypoxia.
Now here, the mechanism is completely different. The lungs are working perfectly. Your PO2 is normal. Your SO2 is normal. But the oxygen content, the CO2, is low.
Because the transporter is broken. The hemoglobin.
Exactly. The carrying capacity is deficient. And you need to quote the formula here. This is mandatory for the exam.
Okay, what is it?
CO2 equals 1.34 times hemoglobin times SO2 plus 0.003 times PO2.
Let's break that down. The first part is the hemoglobin-bound oxygen. The second part is the dissolved oxygen.
Correct. And the examiner wants to see that you understand the relative magnitudes. The hemoglobin part is huge. The dissolved part is tiny. It's almost negligible under normal conditions. So in anemic hypoxia, that hemoglobin bucket is just too small.
And the causes are pretty intuitive.
They are absolute anemia, like from a hemorrhage, but also, and this is key, dysfunctional hemoglobin. Carbon monoxide poisoning is the classic exam topic here.
CO poisoning. Why is it so incredibly dangerous?
Two big reasons. First is affinity. CO has an affinity for hemoglobin that is 250 times that of oxygen. It just bullies oxygen off the binding sites.
And the second reason?
The second reason, and this is the nuance, is that it shifts the oxygen-hemoglobin dissociation curve to the left.
Meaning the hemoglobin that is carrying oxygen hold onto it too tightly and won't release it to the tissues.
Precisely. It's a devastating double whammy. It reduces the carrying capacity and it reduces the unloading at the tissue level.
Wow. And what about methemoglobinemia?
That's where the iron in the heme group gets oxidized from its normal ferrous. Ft2 plus out state to the ferric, Fa3 plus out state. Ferric iron cannot bind oxygen.
And that's often caused by drugs we use.
It is. Crelocaine is a classic one. Benzocaine sprays, nitrites, dapsone. The blood famously looks chocolate brown. Okay, moving on to the third type. Stagnant or circulatory hypoxia.
This is pump failure, pure and simple. The lungs are fine, so your PO2 is normal. The blood is fine, so your HB is normal. But the delivery of oxygen, the DO2, is insufficient because your cardiac output is low.
So we're talking about shock states.
Exactly. Cardiogenic shock, severe heart failure, a massive PE that's obstructing outflow. But you also need to think about local ischemia.
How so?
If you apply a tourniquet for orthopedic surgery, that limb is experiencing profound stagnant hypoxia. Compartment syndrome is another example.
Right. And finally, the fourth type. Histotoxic hypoxia. The engine is broken.
The delivery is normal. The cell receives the oxygen. The PaO2 is normal. The HB is normal. The blood flow is normal. But the mitochondria, the engine, cannot use it. Cyanide poisoning is the absolute prototype.
What's the specific molecular target there?
Cyanide binds to the ferric iron in cytochrome A3, which is complex 4 of the electron transport chain. It just blocks the whole chain. No ATP is made.
And the anesthetic relevance. I feel like that's a classic board question.
It is. Sodium nitroprusside toxicity. SNP releases cyanide as a byproduct. It's rare now because we use it much less, but it's a classic. Also remember burn patients. Smoke inhalation often involves both carbon monoxide and cyanide.
That's a great clinical link. Okay, that covers the classification and mechanisms. Now let's talk about what this actually looks like in a patient. Part D, clinical features and diagnosis.
Right. In an awake patient, the signs are progressive. Initially, you'll see respiratory distress. The patient is breathing fast, tachypnea, they feel short of breath, dyspnea, what we call air hunger.
And cardiovascularly.
Initially, you get a sympathetic surge, tachycardia, and hypertension. The body is desperately trying to compensate by pumping what little oxygenated blood it has around faster.
But that doesn't last. What happens in the late stage?
You see bradycardia and hypotension. Those are very, very ominous signs. It means the heart muscle itself is becoming hypoxic and failing. That patient is about to arrest.
Neurologically, what does hypoxia look like?
Agitation, confusion, restlessness.
Which brings us to a massive clinical trap, especially in the recovery room.
A huge trap. The patient who is waking up wild, thrashing, combative in the PCU. The first diagnosis you must exclude is hypoxia. It's so often labeled as bad behavior or emergence delirium.
But it's the brain screaming for oxygen.
Exactly. Never, ever sedate a restless patient until you have confirmed they are not hypoxic.
Now, in our world, under general anesthesia, patients don't thrash around.
No, they don't. In a paralyzed patient, unexplained tachycardia or new arrhythmias might be the only early sign you get long before the desaturation shows up on the monitor.
Speaking of monitors, let's talk diagnosis. This is an exam favorite. Pulse oximetry, standard of care.
It is, but you must know its limitations. This is a classic Viva trap. The examiner will ask you, Doctor, does a normal SpO2 reading of 100% rule out hypoxia?
And the answer is a resounding no.
Correct. And why?
Because the standard pulse oximeter can't distinguish between different types of hemoglobin.
Exactly. It works on two wavelengths of light, 660 and 940 nanometers. It cannot distinguish oxyhemoglobin from carboxyhemoglobin. So that patient with severe carbon monoxide poisoning will show a beautiful 100% saturation while they are dying of cellular hypoxia. The monitor sees the CO as oxygen. It lies to you.
That is genuinely terrifying. So what is the gold standard?
The arterial blood gas, the ABG, it gives you the true PaO2, the SO2, and it allows you to calculate the A gradient.
The alveolar arterial gradient. Why is that so important for diagnosis?
Because it differentiates the cause. It tells you where the problem is. Look, if you have hypoxemia but a normal A gradient, it means the lung tissue itself is working efficiently. The problem is upstream. Either you're not breathing enough, which is hypoventilation, or there's not enough oxygen in the air, low PaO2.
And if the A gradient is high?
If the A gradient is high, it means there is a problem within the lung parenchyma itself. There's a barrier to oxygen transfer. That's your VQ mismatch, your shunt, or your diffusion defect.
That's a very elegant way to break it down. And of course, we should mention lactate.
Yes, lactate is your biochemical confirmation of tissue hypoxia. It's the marker of anaerobic metabolism. If lactate is rising, tissues are starving, even if the blood pressure looks okay for now.
Okay, we've diagnosed it. We think we know the type. Now, for the most important part, Part E management. This is absolutely essential.
General principles come first. Your immediate action before you do anything else is 100% oxygen. Do not wait for a diagnosis. If the patient looks blue or the monitor is beeping, oxygen first, questions later.
And then the ABCs.
Always the ABCs. Secure the airway, ensure breathing, you may need to ventilate them, and support circulation.
Okay, but then we have to get specific. Management based on the type of hypoxia. This sounds like a very high-yield area for a written paper.
It is. So let's take hypoxic hypoxia. If it's due to VQ mismatch, like in an asthma attack, increasing the FiO2 works very well. But, and this is a critical point, if a significant shunt is present, like in atelectasis or a lobar pneumonia, oxygen alone will often fail.
Because the blood is just completely bypassing the alveoli.
It's completely bypassing them. You can fill the open alveoli with 100% oxygen, but if the blood isn't going there, it does no good. For a shunt, you need PEEP positive and expiratory pressure, and you may need recruitment maneuvers. You have to physically pop those collapsed alveoli open to restore the VQ unit.
That's a key distinction, oxygen versus pressure.
Okay, what about anemic hypoxia? Well, for blood loss, the answer is obvious. Transfusion, restore the carrying capacity. For CO poisoning, 100% oxygen is the primary treatment. It works by decreasing the half-life of CO bound to hemoglobin from about 4 hours on room air down to about 1 hour.
So it just flushes it out by mass action.
It does. And if you have access to it, hyperbaric oxygen at 3 atmospheres reduces that half-life to about 20 minutes.
And for methemoglobinemia, that's a specific antidote.
It is. The answer is methylene blue. 1 to 2 milligrams per kilogram given intravenously. It activates an enzyme pathway that reduces the iron from the useless ferric F3+ state back to the functional ferrous A2+ state.
Stagnant hypoxia.
Fix the pump. If the blood isn't moving, you need to make it move. That means fluids, inotropes like dopamine or epinephrine, and vasopressors.
And finally, histotoxic hypoxia, the cyanide case.
Here you have specific antidotes. The modern preferred one is hydroxycobalamin, which is a precursor to vitamin B12. It binds directly to cyanide to form cyanocobalamin, which is harmless and excreted in the urine.
And the older treatment.
The older kit involved inducing a methemoglobinemia on purpose, using amyl nitrite or sodium nitrite.
Wait, you cause one problem to solve another?
It sounds crazy, but yes. Methemoglobin has a high affinity for cyanide. It acts as a scavenger, pulling the cyanide away from the cytochrome A3 in the mitochondria, freeing up the respiratory chain. It's a biochemical trick to save the patient's life. Then you give sodium thiosulfate to help the body excrete the cyanide complex.
That is fascinating.
Yeah.
Now, you mentioned a limitation of oxygen therapy, absorption atelectasis. Can you explain that?
Yes. This is why we don't just leave patients on 100% oxygen indefinitely. Air is about 79% nitrogen. Nitrogen is inert and poorly absorbed, so it acts as a splinting gas that helps keep alveoli open.
Okay.
If you replace all that nitrogen with 100% oxygen, the oxygen is rapidly absorbed into the blood. If there's even a slight obstruction in a small airway, the alveolus behind it can empty completely and just collapse. That is absorption atelectasis.
Let's pivot now. We've covered hypoxia in depth. Now we need to tackle the second half of that exam question, the effects of anesthesia on respiration. This is part F.
This is pure exam gold. You have to be able to structure your answer here, talk about the effects on lung volumes, the effects on respiratory drive, and the effects on VQ relationships.
Okay, let's start with lung volumes. What's the single most important takeaway?
FRC reduction. The functional residual capacity drops. It drops by about 20%, that's roughly 400 to 500 milliliters, the moment you induce general anesthesia. This happens in almost every single patient.
Why? What's the mechanism?
Two main reasons. First, you lose the tone of your chest wall muscles. The intercostals relax, so the chest wall tends to collapse inwards a bit. But second, and most importantly, is the cephalid shift of the diaphragm.
Cephalid meaning towards the head.
That's right. When you're awake, your diaphragm has tone. It holds back the abdominal contents. The moment you induce anesthesia, especially with muscle relaxants, that tone is lost. The weight of the stomach and liver pushes the relaxed diaphragm up into the chest cavity, compressing the lower parts of the lungs.
And the clinical consequence of this FRC drop?
The danger is that your FRC may fall below your closing capacity, or CC.
Can you define closing capacity for us?
It's the lung volume at which the small airways in the most dependent parts of the lung, the bottom bits, begin to close during expiration.
So if your FRC is now below that point?
It means those airways are closing during normal, quiet, tidal breathing. That leads to gas trapping, atelectasis, and shunt formation.
Okay, what about the effect on respiratory drive?
All anesthetics depress the medullary respiratory centers. The key concept here is that the CO2 response curve shifts to the right.
Meaning you need a higher level of CO2 in your blood to trigger a breath.
Precisely. Your body's thermostat for CO2 is reset to a higher level. And not only that, but the slope of the curve decreases, meaning your response is less vigorous. You breathe less for any given rise in CO2.
And how do the different agents compare? Inhalational versus 5.
Inhalational agents like sevoflurane and desflurane cause a dose-dependent decrease in tidal volume, but an increase in respiratory rate. It's a characteristic rapid, shallow breathing pattern. They also profoundly blunt the carotid body's response to hypoxia. Even a tiny amount, 1 year old at 9, can knock out your hypoxic drive.
And opioids, they're different, right?
Very different. Opioids primarily decrease the respiratory rate. Initially, the tidal volume is maintained, so you get these slow, deep breaths. But as the dose increases, the rate drops further and further until you get apnea. It's a forgetting to breathe phenomenon.
And muscle relaxants are self-explanatory.
They are. Complete paralysis of the diaphragm and intercostals. Zero respiratory effort. You are the ventilator.
Okay, let's talk about the effect on the VQ relationship. This brings us back to something we mentioned earlier, HPV.
Hypoxic pulmonary vasoconstriction. This is a beautiful, highly conserved, protective reflex. If a region of your lung becomes hypoxic, say from a collapsed lobe, the pulmonary capillaries in that specific area constrict.
And shunt blood away from the bad, non-working area and send it to the good working areas of the lung.
Exactly. It's an autoregulatory mechanism to minimize shunt and optimize oxygenation. It's brilliant.
And our anesthetic agents mess this up.
They do. Volatile anesthetics are potent inhibitors of HPV. Halothane was historically the worst, but the modern agents like sevoflurane and desflurane do it too, especially at concentrations above 1 MAC. By inhibiting HPV, you allow blood to flow back into those non-ventilated atelectatic areas. You worsen the shunt and the PO2 drops.
What about regional anesthesia? Do spinals and epidurals affect respiration?
They can. A high block can paralyze the abdominal muscles, which significantly impairs the ability to cough and clear secretions post-op. But the big fear, of course, is a total spinal where the block gets up to C3, C4, and C5.
C3, 4, 5 keeps the diaphragm alive.
Exactly. If you block those phrenic nerve roots, you get diaphragmatic paralysis and respiratory arrest. And one other thing to remember is proprioception.
The sense of position.
Yes. When patients lose sensation from their chest wall, they often feel like they can't breathe. They report severe dyspnea, even if their gas exchange is perfectly normal. You have to reassure them, you are breathing fine, you just can't feel it.
Great point. Let's move into the home stretch. Part G, postoperative and ICU considerations. The surgery is over, the patient is in the PPCU. What are the big hypoxia risks here?
First one to mention is diffusion hypoxia, also known as the Fink effect. This is specific to nitrous oxide.
How does that work?
Nitrous oxide is about 30 times more soluble in blood than nitrogen. So during the case, you saturate the body with it. When you turn it off at the end, it rushes out of the blood and back into the alveoli because of the massive concentration gradient. It floods the alveoli, physically diluting the oxygen that's there.
And how do we prevent that?
Simple. You give 100% oxygen for 5 to 10 minutes at the end of the case to wash out all the nitrous oxide.
What are the other big risks in the PCU?
Residual neuromuscular blockade. This is a huge one. A leading cause of airway obstruction and hypoventilation. You must always confirm adequate reversal, ideally with a train-of-4 ratio greater than 0.9.
And the last one?
Shivering?
Shivering seems so harmless, though. The patient's just cold.
It is metabolically expensive. Shivering can increase a patient's whole body oxygen consumption by 400 to 500%.
Wow.
In a healthy young person, their body can cope. But in an elderly patient with coronary artery disease and limited cardiac reserve, that massive oxygen demand can cause rapid desaturation and can even tip them into a myocardial infarction. Treat shivering aggressively.
Okay, this brings us to the final section, Part H, exam integration. We're in the Viva. The examiner asks you to compare and contrast the 4 types of hypoxia.
You need a mental table. Let's build what I call the audio table. So imagine the columns.
PO2. In hypoxia, it's low. In anemic, it's normal. In stagnant, it's normal. In histotoxic, it's normal.
Okay, only low in the first type.
Correct. Second row, SA2, hypoxic, low. Anemic, normal. But remember, the content is low. And note that CO poisoning reads falsely high on the pulse oximeter, stagnant, normal. Histotoxic, normal.
Got it.
Third row, a gradient, hypoxic. It can be high if it's a lung issue like VQ mismatch or shunt, or it can be normal if it's from hypoventilation or high altitude, hypoxic. For all the others, anemic, stagnant, histotoxic, the A gradient is normal.
Okay, that's a key differentiator.
And the last row, the one for the bonus points, venous O2 saturation, or SVO2. For hypoxic, anemic, and stagnant, the SVO2 is low. The tissues are extracting every last molecule of oxygen they can get. But for histotoxic hypoxia, the SVO2 is high. This is a key finding.
Why?
Because the tissues can't use the oxygen you're delivering. So the oxygen just goes right past them untouched and returns to the venous circulation. You get bright red venous blood.
That point about high venous oxygen in histotoxic hypoxia is a fantastic pearl for the Viva. Let's hit a few final Viva traps before we wrap this up.
Okay, trap number 1. Doctor, does oxygen help in cyanide poisoning? The purely physiological answer is no, because the mitochondria are blocked. But the correct clinical answer is yes, absolutely.
Why?
You give it to maximize that tiny dissolved fraction of oxygen to keep whatever cells are still functioning alive. And more importantly, because in real-world scenarios like smoke inhalation, you almost always have coexisting carbon monoxide poisoning. You always give 100% oxygen.
Okay, trap number 2.
Confusing percent saturation with oxygen content. You can have 100% saturation and be moments from death due to severe anemia. Content is what matters to the tissues.
And a third trap.
Forgetting the mechanism of FRC reduction. If you just say FRC drops in anesthesia, the examiner will immediately ask why. You must mention the cephalad shift of the diaphragm and the loss of chest wall muscle tone.
Visualizing the answer in a written paper is important too.
It is. If you get a long question, draw the oxygen cascade. It's a simple staircase diagram. Start with the partial pressure of oxygen in the atmosphere, which is about 159 millimilli. Then a step down to the alveolus at about 100, then arterial blood, then the capillary, and finally down to the mitochondria where the PO2 is very low, maybe 1 to 5 millimilli. Showing that stepwise drop shows you understand the whole process and gets you easy marks.
Great tip.
And always use a flowchart for short note on hypoxia. Definition, then classification, then mechanism, clinical features, and finally management. Structure scores points.
Senior faculty, this has been an incredibly thorough drill. Let's wrap this up with a final summary. The absolute take-home points for the exam.
Okay, here are the final bullet points for you to remember as you walk into that exam hall.
Hypoxia is not the same as hypoxemia. You must know the difference.
Memorize the 4 types: hypoxic, anemic, stagnant, and histotoxic.
General anesthesia reduces FRC by shifting the diaphragm upwards. It causes atelectasis, and it inhibits HPV.
The shunt does not respond well to increasing FiO2 alone. You need PEEP to recruit those collapsed alveoli.
Treat the underlying cause, not just the number on the monitor. Treat the patient in front of you.
And your final word of encouragement to the resident listening to this.
Be precise. Define your terms. And think physiologically. If you truly understand the why, the what becomes easy. You'll do fine. Good luck.
Thank you, senior faculty. And to our listener, rewind this, take notes, drill these concepts, and go ace that exam. Check out the show notes for a quick visual reminder of those diagrams we discussed. Safe anesthesia, everyone.
Stay sharp.